Welcome to Variations 4. This is the unit on shock, and in this video we'll be covering questions 15 to 19. So number 15, explain why there is pulmonary edema in the systemic inflammatory response syndrome. So I think the big reason here, if you haven't already thought about it, is really it's about that increased permeability, that vasodilation that comes with the systemic inflammatory response. You're going to get fluid going to tissues all around. One of the areas being the pulmonary area. So that really covers off that question well enough for us here. So explain the hypotension in the systemic inflammatory response, and that's really the same thing. We're talking about a massive vasodilation, and we're talking about a drop in blood pressure. So you're getting that hypotension. So again, this is really just an easy summary of what some of the stuff we've talked about already. Number 17, explain 3 reasons for decreased GFR in the systemic inflammatory response. And again, the systemic inflammatory response are things like anaphylaxis, sepsis. So these are those are two those are 2 of the 5 categories of shock. Those are 2 of the 3 categories of the redistributive shock. They are systemic inflammatory responses. And sepsis, unfortunately, is pretty common. And there used to be a poster around the hospital that said, if you don't start treating someone who's gone septic with antibiotics, the mortality rate goes down by 10% an hour. And so in 10 hours, they're dead. So it's a pretty big one out there. But that's the hypotension for the inflammatory response. And then, 17 is a GFR. Well, of course, you got the hypotension. So the etiology of hypotension we've just talked about. That was question 16. Then you've got disseminated intravascular coagulation. So first of all, you've got the paradoxical 2 things going on. Number 1, you've got a bleeding risk. So maybe the patient's bleeding. So they're losing blood volume, and that would certainly decrease GFR. Or maybe it's the other problem with DIC, and it's the microemboli, and they've got some microemboli in the vessels carrying blood to the kidneys. So now the kidneys aren't being perfused because of the emboli. That could certainly decrease GFR. Why would there be decreased serum albumin? Or if you remember, if there's liver failure, like that could be an organ that's failing in this multi-system failure. If the liver's failing, one of the things it might not be able to do is synthesize albumin. And albumin's got major oncotic pull. And so without it, fluids moves even more easily to the tissues, thereby increasing edema, also decreasing blood volume in the vessels, and that decreases blood pressure, decreases perfusion, decreases GFR. 18, again, another nice summary here of something we talked about before. I mean, if you're wondering where I'm getting this from, or you want to get it from the textbook, I also put it in the concept maps right here. So early on, you are converting glycogen to glucose because you have this major metabolic needs going into the stress response. Blood sugars go up. Long story short, by the way, the process of all this using protein stores, if that's what's happening, and can actually also cause that lactic acidosis discussed in the earlier question. Anyways, back to the question at hand. Eventually, glycogen stores will go down and you'll go hypoglycemic. So you might start off hyperglycemic, run out of stores of glycogen, and then go hypoglycemic later on. Finally, question 19. For each of the 5 types of shock, explain why or why not aggressive IV fluid therapy is appropriate. Well, I'm going to let you read through that yourself. Okay, you need to read through that yourself. I'm going to go over it in a nutshell right now. Generally speaking, here's how it goes. Cardiogenic shock. Why would you not want to bolus things really quickly? Well, you might. I mean, in all these cases, you might. But here's why you have to be careful. Bolusing too quickly with cardiogenic shock could put a sudden increase in workload on the heart and make your heart failure even worse. So you're putting increased workload on the heart when you give boluses. Now, I'm not saying you don't give boluses when there's cardiac issues. I'm just saying it's a balancing act, and you have to watch out for the amount of workload you're putting on the heart. So think carefully about cardiogenic shock, and the physicians will have to think carefully about how they want to bolus with that, because it could put workload on the heart. Okay, second type of shock, hypovolemic shock. I don't see any issues there. Just keep the fluid going. Get that fluid going in as fast as you can. Generally speaking, shouldn't be an issue. Next one, septic shock. Well, of course, the sepsis, you're doing other things to counteract the problem, whether it's antibiotics or, vasopressors or whatever. But generally speaking, yes, it should be okay to give those fluids to resuscitate. Hopefully you can dampen this inflammatory response so you don't get all that fluid flowing into tissues. But yes, generally speaking, you're going to be bolusing with that sepsis for sure. Same thing with anaphylaxis. Can't think of really a good reason why you wouldn't be bolusing if someone's dropping blood pressure because of inflammation with anaphylaxis. And finally, neurogenic shock. Be careful because, again, remember, you've got a low blood pressure, but you've got a low heart rate as well, because the parasympathetic system is uninhibited. So if you start bolusing that, two things. Number one, can the heart manage that? Okay, can it manage that because the heart rate's low and sympathetic tone is down? And the second thing is when that neurogenic shock runs off, you're going to get that kind of reconstricting of vessels, and you're going to have all this fluid you're pumping in. Are you going to suddenly increase afterload too much, thereby, again, the concern of overworking the heart? That's a nutshell of what is said below here.